It's a great day to talk rehab, and today we're going to talk about occipital neuralgia. So this is for Dr. Paul out there who asked me about the treatment of occipital neuralgia. Well, number one, you have to figure out, is it inflamed? So we have our greater and lesser occipital nerves. They come out from underneath the atlas. The lesser occipital nerve just stays in the occipital region. The greater occipital nerve was going to come out all the way up to the top of the head. So your occipital neuralgia, your occipital neuritis will tell you whether it's the lesser or the greater. And again, the first thing we got to decide, is it inflamed? Well, what I like to do is I put an ice pack over the area and see if it mitigates, if it lessens the symptoms. If an ice pack lessens the symptoms, we know it's inflamed and we know there's a local irritation. Now, as we mentioned, the occipital nerve comes out between the atlas through the suboccipital muscles. That compression can be mechanical at the atlantoaxial joint, or it could be myofascial from the fascia, or maybe just from one of the suboccipital muscles creating a contracture. Yanda's upper cross syndrome, here suboccipital muscles are going to be shortened and tightened. It could be that simple. So the first thing we need to do is figure out, is it truly inflamed or is it a compression syndrome? Because if it's inflamed, we got to shut the inflammation down. Ice is a great place to start. Topical phytazole, CBD, works really well. You can also go into pharmaceuticals. Medical docs will often use cortisone. They'll also give injections to the area to shut down the muscular spasm. However, what we need to do is look at, let's say there's some arthritic degeneration in the area. What we need to do is to open up those joints to get the compression off it. Now, this isn't the occipital nerve, but it's the same concept where the joint is all arthritic, there's less joint spacing, and the nerve's irritated. So chances are you're getting some sort of irritation in the kinetic chain. So where are we going to start? Let's say it's not really hot, but there's a lot of, meaning inflammation, but there's a lot of spasm in the suboccipital group. Graston with GT5 works really, really well. Just using the weight of the head, getting up and just milking it. That's a really effective way to open up the suboccipital muscles. If it's an acute neuritis, this is going to aggravate it. So you wouldn't want to do that. This is if it's more of a myofascial pain syndrome. And you can do it in rotation. You can do it in rotation. Then we can also bring them up into flexion and really get some authority on that. Can you use your fingers? And do it with your fingers as well. You can also do it with the fingers. Just make sure you use a broad-based contact. SOT stair step, great. Gets everything moving nicely. Do the figure 8 on each level of the stair. Very good, because that will help mobilize the whole cervical spine without creating too much irritation on the greater or lesser occipital nerves. You have to do a thorough joint play assessment. Is there joint locking at C1 occiput? If there is, you got to get that occiput opened up, all right? You can do the old occipital lift. You can do it supine or prone, but you got to adjust the occiput. Old school toggle works great. For degenerative conditions in the lower spine, again, your stair step is excellent, manual traction, or even cervical traction. With or without mechanical devices, just using your hands or an attraction device. But again, if the patient's here, we got to get that sagittal plane line fixed, get the ear over the shoulder, get the chest up and get the shoulders down to shut down the levator scapulae and the traps. So that's really, really critical in terms of the long-term rehab. Locally, to stretch those suboccipital muscles, chin in, and go into flexion. Same thing we were doing here. I'm pulling the chin in, and then I'm bringing them up into flexion. All right? I got my broad-based contact on the suboccipitals, chin down, and then bring them into flexion. Pin and stretch of your inferior and superior oblique. You can do that as well. Contralateral rotation, start just opposite the lateral mass of the atlas. traction and stretch towards C2. All right? And you can then grab and rotate the other way. So you get your lesser and your greater occipitals with pin and stretch that way. Works great for all your myofascial components. Check the temporalis, check the TMJ, because myofascial tightness here could manifest itself back in here as well. So is there a simple A treatment for occipital neuritis? Not really, but like anything else, it starts with an adequate assessment. Is it inflamed? Is it a local issue? Or is it a compressive issue in the myofascial chain? A lot of times, thoracic spine's an issue. So get that thoracic spine adjusted before you even adjust the occiput. Because if they're here, and if they can't get here, that's a huge problem. So getting adjustments and getting the thoracic spine open oftentimes will open up that occiput. If that doesn't do the trick, then you work from the bottom up and just ice the neck until it calms down. And nutraceuticals, anti-inflammatory diet. Watch that whole playlist because you got to shut down the inflammatory cascade. You can do it with diet, you can do it with supplements. You know, they're safe, they're simple, and they're effective. So there you go, doctor. That's for you. There's your occipital neuralgia tutorial. I hope it helps. And if you have any questions, let me know. Have a great day.